So now I get to introduce Susan Johnson. Again, I don't feel in many ways that she needs much of an introduction. She's been in the healthcare world for years. She's a fantastic leader. She's a colleague of mine for decades. She's someone I call to go, oh my gosh, did you hear this? Or what am I going to do about that? She's got a tremendous perspective. She served as the director of King County Health Action Plan for the Public Health Department in Seattle and King County for 12 years, prior to her appointment as HHS Regional Director in 2009. In that capacity, she's developed and implemented innovative programs for children, teenagers, and persons with chronic diseases. Prior to her work at King County, she was appointed by Governor Lowry to the Washington State Healthcare Policy Board, where she represented the concerns of consumers and workers in the development of health policy recommendations for state officials. And from 1984 to 95, she served as the Director of Governmental Relations for the Washington State Council of the Service Employees International Union. So it's my absolute privilege and pleasure to introduce Susan Johnson. I hope you enjoy what she has to say.
Is a reunion. It's like swallows coming back to Capistrano, I think, and it's great to be with you today to celebrate all that you've all been working on with the grant and innovating, testing, and to celebrate also the huge waiver and the $1.5 billion and the preliminary agreement that is coming your way in the future. So first off, just congratulations to all of you. I want to offer just a few remarks at the outset, representing Secretary Burwell and this administration, a few comments at the national level, and yes, eyes are on Washington. Yes, the Secretary does know what's percolating out here, and everyone is very excited that you are one of the, I always try to say petri dish, and that sounds like it's a negative thing, but what you're growing out here that can be useful to spread across the country in a good virus kind of way. But as we know, eyes of this administration and incentives provided by this administration are looking forward, as we know, to paying for not more volume but more value, to testing out alternative payment mechanisms, to looking also at a new focus on multi-payer opportunities for coordination. We're looking, of course, at more emphasis, the spotlight on prevention and integration. In my lifetime, I hope to see not just the mind joined to the body, but the mouth as well. We've all worked on that for many years. So joining the mouth and the mind to the body in a holistic sense is a precursor to the holistic sense that Dorothy talked about of health beyond healthcare. And we know that that's what you're working on. Secretary Burwell has set ambitious goals for Medicare improvements in these ways, and funded through the Innovation Center, we're testing out many things in the states, such as you've been experimenting and putting forward for the past several years. I want to just highlight a few things going on in this region, Region 10, which I know is the best region in the country. You know, it is. Who said that? Karen. We have, in Washington, as I mentioned, all the progress that has been made on the ground with the Innovation Grant and now continuing through in the new waiver, the focus on prevention, integration, and the accountability with the ACH is at the community levels, where you can really get traction and focus on the issues beyond health care, beyond medical care, to housing, to jobs, to food insecurity, to stability, to all of those words that we know create a foundation for health. In Oregon, we have, in a sense, some precursors, some good lessons learned there to look south and see the 16 CCOs that have been working for 4 years there and the modeling that has occurred. They're working also on a waiver for the next 5 years. And they have a renewed spotlight, as we all carry with us here, a focus on social determinants of health in that expanded view of health. Idaho, interestingly, despite the lack of ability to get to Medicaid expansion, but in my 9 weeks left, Maybe. I don't think so. But we're going to keep working on it because there are 75,000 Idahoans in the gap. And it's a cruel situation in my mind. Nevertheless, they are working on great programs with patient-centered medical care and renewed efforts around telemedicine to do all that they can. And I think that despite the 60% poll that supports Medicaid expansion, we don't have the required votes in the State House and Senate. Alaska, also a great state in my region. I go up there a lot. In fact, somebody said, do you have a condo in Anchorage yet? And I don't. But it's a wonderful place for innovation because of some of the characteristics of the state that you all probably know just force people to come to do things differently. With 229 federally recognized tribes, also an incredible NUCA system of care that I know many of you have heard of and visited with and learned from, there is a great network of opportunities up there for innovation, such as we see also here. The DHAT program, the Dental Health Aid Therapist program that started in Alaska is now in Washington, the Swinomish tribe. I don't know if anyone's here from that tribe, but they have taken tribal sovereignty to a new level and produced that program right there in their own community. And I think it will spread throughout our state and through other states in the lower 48. The CHAP program, too, Community Health Aid program, is coming down through IHS new guidance to the lower 48. And I think that can help us not just in the villages of outside of Barrow in Alaska, but right here in Tukwila, where we need more on-the-ground focus with trusted messengers to improve health. Behavioral health aid as well, come to us from Alaska, can help us here in our work of integration. So in conclusion, I just see again in this room and across my region, all that we can learn from each other, all that is there to be shared, that there should be encouragement across the states, and I think there is, to learn from mistakes. As Dorothy said, stop doing what isn't working, move ahead to something new that can work, and continue to work together. I see sort of an invisible sign that maybe we all can see and others will eventually, a big button that says the way we've always done things with a big red line through it. And that's what we're all about, is finding out what's next, what will work, what can work. And I know with the energy and leadership in this room, Washington will continue to be healthier than we've ever known it. So thank you very much, and I look forward to a great day with you.
Well, thank you, Susan. That was great. And we are going to get rolling right away to our first plenary session of the morning. And I'm going to invite the panelists for that plenary to the front. Rick Cooper, who hails from DaVita Medical Group, Daryl Edmonds from Amerigroup, John Espinola from Premera, and Alison Carl White from Better Health Together in Spokane. As they're joining us on the stage, I'm going to set up briefly what we're intending to accomplish in this plenary and the breakout sessions that follow. As you've heard now in comments from Dorothy and Susan, a healthier Washington is about rewarding good health outcomes by paying for quality and value over volume. And we have set ambitious goals, as has CMS, to reach in coming years. And we know there are some barriers and challenges in reaching those goals. So this panel is going to explore progress that the state has made in moving to a value-based system for the Medicaid and public employee programs, as well as the broader commercial market. This discussion is going to illustrate, I'm sure, how far we have to go to reach our goals and the opportunities that we have yet to fully realize to spread value-based models in the market, change and deliver upon new expectations for plans and providers, and engage community-based organizations in that shift to value. Rick Cooper, why don't you take it away?
Good morning, everybody. Can you hear me? Well, I'm feeling pretty good this morning. How are you feeling? I mean, leading into this morning's session, I just had this wonderful experience last night. It was one of the most invigorating football games I've watched. And I I know that's got you jacked for what Nathan commented on earlier, and that's engagement and interaction during the day. And I slept like a baby last night, and so I'm ready for a good conversation. My task today is to talk about something, tee up this conversation that's important to me, and that's how financing of care works in the communities that we serve in the United States, more broadly. And we've made progress, but we have a significant way to go, in my view, to produce healthier communities and a healthier Washington. Joining me for the conversation is Daryl Edmonds from Amerigroup, Washington, Dr. Espinola from Premera Blue Cross, and Alison White from Better Health Together. So what I want to start out with is tee up this conversation about incentivizing and rewarding health with an observation about the market from my perspective. And I think generally there'd be agreement about this, but there may be disagreement, and that's fine as well. First, a characteristic of our system is that it's too darn expensive. It's too darn expensive from the point of view of those paying for care, be it the federal government, the state government, plan sponsors. But throughout my remarks and the conversation today, I really hope we all think about this through the eyes of patients and consumers. And it's certainly too expensive from the point of view of those trying to access our system. We have a highly consolidated marketplace. It's a mature industry, but it's highly consolidated, and that has various implications. This market might be a little bit later to the consolidated environment than some around the country, but nonetheless, it's quite consolidated. For those of us who spend time listening to patients, observe about what it's like to access our system, or those on the front lines trying to make it work, I'll tell you the healthcare system is increasingly complex, and it's very frustrating. The complexity itself is causing frustration that, interestingly, I didn't anticipate after the passage of the Affordable Care Act. In many ways, it's more complex now than it was beforehand. So it's an interesting observation. There's growing demand for transparency. And in a highly consolidated environment, what are we to do to have a level playing field for the consumer in the absence of a very transparent industry? Pricing is confusing. I'm not sure it's as complex as the mobile telephone business. For those of you who have tried to understand that pricing model. But nonetheless, you know what I'm talking about. It's very, very, very complicated, and there's so much variation to it. And just to digress for a moment, in the northern end of Snohomish County, you know, the price for a chest x-ray when a patient accesses the system and needs can vary from $70 to $400. I mean, what's that all about? And it just doesn't make sense. And the system is, as both Nathan and Dorothy and Susan, for that matter, all talked about, is a system that's wanting to move to reward those who deliver value with lower cost of care. So kind of where are we right now? Healthier Washington surveyed providers and health plans. And current state is somewhere between 10 and 30% of those who responded believe they're in some form of value payment mechanism. And Nathan talked about what the goal was in 2017, and I think by 2021 the goal is 90%. Now, by my way of reckoning, the only way you're really going to drive transformation and innovation is if you get to 30 to 40% of the total market. That's Medicare, commercial, public exchanges, and Medicaid are really in true value-based payment. And on the end of the continuum, that'd be prepaid care. But there needs to be alignment among those different financing sponsors, and it needs to shift away from our current system of piecemeal reimbursement. The irony in all of this is everybody wants the same thing. Purchasers want high-quality, affordable care that keeps their employees healthy. They don't want pressure paying more and more for care. Patients want high-quality, affordable care that keeps themselves and families healthy. And they don't want the pressure of paying more and more for care. And providers want high-quality, affordable care that keeps patients healthy. I might amend a comment that Dorothy and Susan made about triple aim. I think about this in terms of not triple aim, but quadruple aim, because there is so much unhappiness among those who are in the healthcare system, and it's truly unfortunate that aside from triple aim, being able to create a healthcare system in this state where people really enjoy getting up, going to work, and partnering with patients to improve their health is something we should all aspire to. So we have a few levers. We have a few levers to move us from where we are now to where we may want to be in a future state. First is transparency. We should all insist upon it. We should all insist that every provider of care posts their prices. We should insist that providers and health plans and plan sponsors collaborate together to sort out how can we efficiently and effectively let patients know what their out-of-pocket payment is going to be at point of care. Secondly, a significant key lever is the evolution and transformation of clinical models. You'll hear more about this today, but the role of behavioral health is increasingly important. It always has been. It's called out in the Affordable Care Act, but we have a long way to go to the mandates of the Affordable Care Act and what is occurring in the marketplace. I feel one of the real jewels at the Everett Clinic is a thriving behavioral health department that is integrated into our primary care model. We have over 50 providers of care, and so it's essential for the entire population of patients we're caring for, but particularly critical for high-risk patients. And so financing can reward the continued evolution and development of behavioral health. Benefit design and financing, there needs to be alignment. There needs to be alignment from the point of view of between health plans and providers, encouraging providers to practice appropriately. There needs to be benefit design that encourages individuals to access efficient providers, and there needs to be limits on the spend. And so we have to get commitments on what the spend rate is over time, and we need to be increasingly thinking about a budget of care for health care. Variation is alive and well. We have so much variation inside the Everett Clinic, not to speak of the variation that occurs out in the marketplace. And so that in part is a function of our financing system. Fee-for-service medicine in an affluent society actually enables this to occur. And so we need work to reduce that variation, and in the end result will be improved health and less costly care if we're successful. And the final comment I have on key levers really is something that was attended to in the opening remarks, And what a wonderful environment we have here and a spirit of collaboration. And I think about this with 2 weeks to go. I think about what we can do together to collaborate to produce a different system of financing, how care is organized in a different way that ultimately will produce a healthier population and a health manpower that truly enjoys what they're doing. This is only going to be accomplished through collaboration. It's a very, very complex industry. And so it's the spirit of collaboration that gives me the most reason for optimism and hope that we'll be successful over time. So that's how I choose to frame the issue of rewarding financing, rewarding a value in financing care. And I'd like now to pivot to questions for the panel. And I will invite the folks in the room, if you have a question, a different point of view, we will get mics to you so you can ask the question or make the comment. So my first question will be for Espy. We all agree on the goal to move to value. How do we support providers in getting from here to there? What are the challenges? Why haven't we been paying enough attention to that? And what do you see as the opportunities, resources, or tools in front of us to make this transition easier? Go for it.
That'll be the first hour.
You've got 5 minutes.
Yeah. Well, we should have asked someone else if you wanted it in only 5 minutes, Rick. You know that. Good morning, everybody. You heard Rick call me SB. That's what everybody who knows me calls me. So I'll just clear that off the table. Probably there's a lot to talk about in that question. I think that one of the most important things to do is start with a common understanding of what value is and through whose perspective we need to define value. And I would say one of the greatest challenges we've got today is that it's variably defined. Rick talked about variation in healthcare. We've got variation as thought leaders about how we think about this challenge. And it's largely driven by the position from which we look. I represent a purchaser for commercial health insurance largely, and on the individual block, there's one perspective. Rick represents a medical group. There's another perspective. There are community stakeholders who have other perspectives, and there are policymakers, a long list. Until we get clarity, we're going to continue to have fragmentation and confusion and distortion of our efforts that lead to pulling in multiple directions and difficulty getting traction. So I'd probably put that out there as one of the greatest challenges we've got. I would pile on to something Rick said about transparency. And I think about how healthcare would work if Amazon ran healthcare. Think about what Amazon did. They created a ruthlessly transparent environment where you can try to purchase anything, and every supplier has to compete for your attention and your business. And they do so on an even playing field around price and what other customers have said about the quality of that sell. Imagine if we had Amazon running healthcare. I think it would be quite different. And I think one of the first things they would do is create a ruthlessly transparent environment and force the supplier of healthcare, the provider community, to compete for people's business based on cost and quality. When we think about what we could do to support providers, which I think is part of the question Rick asked, there is a lot there. First, maybe I would say we clarify what we mean when we talk about value in terms of, are we talking about it with regard to health or health care? Most of the reimbursement methodologies in this country and in this community involve health care, the transactional activity of providing a service to someone. Sometimes those two things overlap quite a bit and we get confused, and we're trying to ask a certain payment model to do both, and that can be really challenging. So I think one of the things we can do is help providers have clarity about what we're paying for, what the expectations are, and get them on a glide path towards value-based care. And that glide path, I think, is pretty important because we have to recognize that we have a hyper-fragmented community. Payers are fragmented, providers are fragmented, others are fragmented. And we have to recognize that all of these organizations are at different stages of development and competency in the ability to actually provide healthcare in a value-based way. We can help with that as a payer community by providing expertise, transitional financing models, even clinical programs that might gap fill where a provider doesn't currently have capabilities. Rick mentioned behavioral health. I think about other vulnerable populations, the geriatric community, the homebound community. There are many communities that are currently underserved. How can we as a payer community help by bringing those to bear? Lastly, I'll think about what we should pay attention to, the patient. I bet the patient is underrepresented in this room today, and I think the patient is actually what matters. So I appreciate the comments that Dorothy and Susan and Rick made about bringing the patient to bear. We have to pay more attention to the patient, make sure it works for them, because that's first and foremost who this is all about. We also could pay more attention to each other and look outside our four walls from whatever organization we work in to try to be collaborative, try to recognize the needs and challenges of other organizations and help build a bridge. And then I can't overemphasize paying more attention to transparency, because nothing will change until we can see it.
Daryl or Alison, any follow-up comment? Estes remarks?
Well, I think the other thing that I would add to this is such a massive change management initiative, and that there is a need for some graciousness in what pressure we're putting on all of these systems to change so dramatically within each of those different sectors of things that make you healthy, but then this incredible pressure to now learn a completely different language, a completely different financing methodology. And we're all doing it in a constrained environment where that pressure to balance our individual work environments with this broader movement that feels really important to recognize. And I appreciated Dorothy and Susan's comments about just celebrating how far we had come. There doesn't feel like a lot of celebration or a lot of patience with how hard this work is.
You know, one of the significant achievements is obtaining the waiver. And so, Daryl, in light of that, given that we have the waiver, how will that serve as an accelerator or an enabler for the movement to pay for value?
Sure. Let me just start my remarks with saying I think that Dorothy, Nathan, and Marianne have done a tremendous job. When we look around the country, a number of states have not been granted waivers, so I think their leadership and their dedication deserve a round of applause. I mean that sincerely. I think that the waiver gives us an opportunity to do things that we have talked about, we've thought about, we've wished for. But I think now that we have been granted approximately $1.5 billion, we're going to be able to do some of the things that we've just talked about or thought about. When I take a look at some of the things that we're going to be looking at in our MCO contracts for next year, and we know that there's going to be 1% around tied to value and quality metrics. That's great. When we take a look at the value-based purchasing, that to me is the right approach as well. Again, at Amerigroup, we have been embarked on that path the moment we came to town, which was in 2012. And so we believe that that is really the way we need to be going. I pity the provider CFOs who are trying to balance value-based purchasing with fee-for-service, and how do you make that work? That's really a struggle, in my opinion, as we begin to see more and more of the payment for Medicaid, Medicare, and commercial move towards value-based purchasing. I think it's going to make their lives a lot better if they'll be able to sleep 3 or 4 hours a night, probably, as opposed to 2 or 3. I think when we take a look at getting the construct right. I think it's important to really understand, not just from an MCO perspective, but what's important to the provider. And as it's been said before, what's really important is the patient. When I stop and think about what we've been able to do over the past 2 or 3 years with the expansion of Medicaid, and we talk as a team that if we can help people get access to health so that they can get or keep their health, get access to health care so they can get or keep their health, we can change the world. And sadly, there are a lot of people in the state of Washington today who've given up hope for that. And if we can engage with them, we can give them hope. If we can give them hope, we can change the world. To me, that's really exciting. That's what we're about. As I see the challenges that we have today, the challenges really is around data. And how do we ensure that we can get good information to the providers to do the work that they need? For those that remember, some of you will not in this room, but I remember when we would get a report and it would be a stack of green bar paper. And it would be, here's your report, Daryl, and it would bump on the desk. And like you, it's like, well, what does it say? Well, I don't know, but it's all the data. I think we are thinking that if we can do that with providers, jobs accomplished, mission solved. That's not true. It's how do we use the data in such a way to transform the care that's delivered to the patient. That's one of the biggest challenges I see today. And one of the challenges around that is where does the resources to pay for that come from? So for me, when I take a look at some of the waiver dollars, it's going to help to transform the care that's delivered in a value-based purchasing arrangement. Second point I would make around quality metrics, and I could support that more, is which metrics do we choose? When we look at the common measure set, there are, I can't keep up with that, 52, 53, 54, somewhere around that number. How can we manage to that number? In conversations I've had with providers, they have said, I can't do that. And I said, well, the good news is all those measures don't apply to you. You don't have to do them all. But which ones do you want to work on? And in conversation with some of the providers, they're picking some that they really want to work on, some that we want to work on to, again, improve and do population health management. I think that the waiver is really going to help to accelerate that in a number of areas. Last but not least on that is around behavioral health integration. We've talked about it in this state for a long time. We know it's coming. We know that we have gone from 3 silos or 4 silos, depending on how you look at it, in providing care for those who are served by Medicaid, whether it's physical health, mental health, substance use, and then dental. We've consolidated the mental and substance use disorder into one. Now it's behavioral health. In Southwest, they've integrated that one step further in physical health and behavioral health. Dental is still out there. I think as we see what transpired in Southwest, roughly 2 years in preparation for that work. Where are we from a regional perspective? How can the waiver help us to accelerate that work, to move towards patient-centered care around physical and behavioral health? If we can keep the patient in the center of that, put our differences and perspectives aside to focus on that, I think we're going to see a transformational difference in the state of Washington.
Thank you. Alison, how does the ACH play a pivotal role as we drive the population health?
Well, I think my colleagues around the state would really agree that when we launched these accountable communities of health, they were sort of an interesting idea of bringing healthcare and social determinant of health organizations together to start to really create a shared vision. And I think what many of us found very, very quickly was that shared vision was incredibly easy to come to. There wasn't anybody saying, gosh, I don't really think that if you don't have a place to live or enough food to eat or enough income to pay your bills, you're certainly going to hit those high quality health status. And we didn't hear folks who were running housing programs or food programs saying, this Affordable Care Act and people having insurance, it's sort of okay. what we heard was, yes, this is very much where we need to go, and we don't know how to intersect, but we know that the folks that we're serving are not well taken care of when these sectors don't intersect with each other. And so I think in a very short period of time, the accountable communities of health all around the state, which, I actually think we should give a round of applause to this from the ground up movement that has joined forces with a system-wide approach to come together, that in every region across our state, we have literally hundreds of organizations coming together. So could we take a moment and say, good job, ACHers? And because I have the microphone right now, we will also do a shout out to the tireless efforts of the ACH leaders all around the state who have done that. I think most of us are fully represented. Laura's nodding at me. Yes, we are all here for that. So I think they all deserve a yeehaw. I can't believe I got the west side, mostly the west side of the state, to say yeehaw, but that was kind of cute, wasn't it? Anyhow, I think though this first year and a half of ACH work has really been the easy part of bringing people together in a shared vision. The value add is really the next, I would say, 18 months of can we make this thing be a thing? And I am so encouraged as each of the ACHs roll out their regional projects that are designed to be multi-sector in nature, that the creativity and the challenging the status quo is really there. I think we're starting to see the value proposition of what it would mean if we organize community assets in a way that allowed the healthcare system to easily reach into the social determinant of health community, and the social determinant of health community an easy way to reach into the healthcare sector. And I think as we move towards more opportunity to do that, not in just a pilot effort around a variety of different regions, and I think, Washington State is known for its innovation, and we can point out a number of just amazing projects, but they are single populations or neighborhood-based or a particular region. They are not systemic, nor are they population-driven. And so, to me, the ACH, one of its biggest value propositions is this ability to move from pilot to sustainable population health efforts.
Questions from the audience for the panelists? I'm sorry, I didn't make that clear. Are there any questions for the panelists? Yes, in the back. We have a mic. Thank you.
And this is for SD. And also, I'm sorry, I'm forgetting names, and I should know their names. Also Daryl.
I forget it sometimes too.
Okay. It's okay, Daryl, and I should know you because I used to work in Medicaid. So anyway, my name is Barbara Lance, and I work for the Healthcare Authority, and I've been doing a lot of thinking about, in my head, about the role of a managed care organization, and looking 10 years or 15 years down the road. How do you see the role of the managed care organization changing given the conversation we've been having today? Do you see, Daryl mentioned analytics and the need for a stronger analytics unit to really be able to analyze data and get that data down to the primary care provider or specialty provider setting, for example. So could you comment a bit on that?
Absolutely. Thanks for the question, Barbara. I think the role of the MCO, or asking the question about what is the role of the MCO, helps us get a little bit at what the problem is we're trying to address. One of the challenges, back to Rick's opening comments, that I see is sometimes we can be a little bit myopic in how we perceive the problem. Or maybe we sometimes believe there's a silver bullet. And payment reform is often held up as one of the holy grails that will solve almost everything. It's an important part of the equation, but I tend to start with the problem we're trying to solve, and I put it in patient terms and simply say these 4 things, sort of monotonously, so everybody in the room who's ever been near me has probably heard it. I think in our community, patients pay too much for what they get. Or I would say customers pay too much. Maybe we use the word customer. So that big C customer is purchaser, whether it be a state purchaser or a self-funded employer, or little c customer, an individual patient. But they pay too much for what they get. And why do I say that? Because I think what they get is too often they're not getting the care they need. We see evidence all over the place that people get care, but for some reason, women who see the doctor don't always get mammograms. Kids who see pediatricians don't get vaccinated. Men in their 50s who see the doctor may not get a colonoscopy. So people are not always getting the care they need. That's the second problem. The third problem is people are often getting care they don't need. And that's a big problem because anything you don't need is, by definition, harmful because there's not a single thing in healthcare that is risk-free. Not a single thing. And we're naive if we think it is. So any healthcare that's not needed that you receive, whether it be a substitute for someone taking time with you to ask you questions, whether it be a shotgun approach to cover your symptoms and get you out because I'm running late and prescribe the antidepressant because you're bugging me, the pain medication, a couple of x-rays and labs to figure out what's going on. All that can be harmful if it's not necessary. So that's the third problem. And then the fourth problem is that patients don't have the experience they want and deserve as human beings. And that goes back to time immemorial, this profession of healers and patients. It's always been a sacred part of society. Healers have always been granted a certain authority in society with a social contract that they will take care of others. So I say that is the problem we're trying to solve. We're not trying to solve financing, we're not trying to solve anything. So financing can be a vehicle to help solve those problems. So now we get to the role of the MCO. I think the MCO has to single-mindedly pursue solving those 4 problems. That is it. Pretty simple. And for me, it's helpful to put it into simplistic terms, first of all, from New Hampshire. So that helps, right? You're going to put it in simple terms. But secondly, I think if we do that, we're standing in the shoes of the people we're trying to serve, which is the patient. And when we look at it through their lens, we see these 4 problems. I'm paying too much for what I get. Too often I don't get what I need. Too often I get what I don't need. And my experience stinks. So the MCO, the data and analytics is an important piece of it, but it's not in and of itself relevant unless it can help providers address those 4 problems. Can you identify people who are not getting care they need? Can you identify people who are getting care they don't need? Can you identify cohorts of your patient population who aren't having their emotional, social, and human needs addressed in their experience? And of course, cost perspective. So I think the MCO can become an aggregator of capabilities to help deliver those to the provider community in a way, of course, that the provider community can receive them. So there has to be some flexibility and accommodation to the fact that not all providers are created equal. Rick happens to have built a very advanced and forward-looking organization up in the Everett clinic that can invest in certain capabilities that mild practice could never dream of doing because we just didn't have the scale. So an MCO, I think, aggregate resources, aggregate capabilities around analytics, financing, and the piece that I think we often leave out is clinical models. I think an MCO needs to have the courage to actually bring clinical services to bear. Not every provider can do everything. There will always be gaps. The system may not support funding home-based chronic care, for example. on a routine basis. I'm a geriatrician. I happen to do a lot of home-based care when I was in practice. But I was a rarity, exceptional rarity. So I think about that as a capability as well. An MCO which can concentrate risk and patients and financial flows can actually afford to bring scale to invest in certain clinical models and gap fill where appropriate. Not, of course, stepping on toes or whatnot. And that's where I think it's important. I appreciate Alison's comments. I wrote down almost a sense of compassion for each other and where we're coming from and the difficulties we face. And I recognize that providers are all starting from a different place. Let's have compassion for that and work with them. We believe that we will be successful if we work with and through, not against providers. So that's sort of how I think about it, Barbara. Not a lot of specificity, because I think sometimes we dive into the specificity and we lose sight of the end in mind. The end in mind is the problem we're trying to solve for the patients.
Daryl?
Quickly, I'll just say three things. One is, we at Amerigroup, we view that our customer is the state of Washington. So we need to help them to do the work that they want to do, which, as we've talked about, is move towards value-based purchasing. 30% in 17, 50 in 18, 80 in 19, and 90% in 2021, as an example. So to help them to do what they believe is important for the patient, the client in Washington. Second is to collaboratively work with providers. If they're not successful, we're not going to be successful in maintaining an adequate network, particularly in the rural areas, for the clients and the patients we need to serve. So to work with them in such a way that we can sustain their work and to help them to innovate by giving them not green bar paper in 5-pound packages, but actual actionable data. Third, I would say to continue to work with the ACHs. When I think of the work that the ACHs are doing today, it's a concentric circle. In the middle is a patient, and then we come out, whether it's physical health, behavioral health, supportive housing, supported employment, food. How do we take those circles, concentric circles, and draw linkages between them? I view our role as an MCO to work with those ACHs in such a way that we can work alongside and collaboratively to create the linkages between those services at a regional level.
I'm sorry. Jerry?
Hi, I'm Jerry. Taking off from Rick's question, why aren't we not doing this now? And John's answer, there are many perspectives and finally getting to the point we need to think of the patient. My question really is, why is there not a better voice for the patient, for the individual patient? We are representing different constituencies and 900-pound or 90-pound gorillas, but the patient does not have a good voice. Even when we're doing things that are patient-centered, the patient doesn't necessarily have the voice. So we're speaking on their behalf. And it seems like the ACHs might be an opportunity to actually cultivate the voice of the patient. So, for instance, like with quality, as a patient, if you're lying in bed, you hit the button and nobody comes, that's a good measure of quality or lack of quality. So really we need to listen to the patient and create a voice where we can hear the patient. And the question was, how would it look like if Amazon was running it? I can guarantee you that the patient would have a voice if Amazon was running it. So I guess I'm asking the question, how can we build a better voice for the patient?
Sure, I'll take a stab at that. I think you're right that the accountable communities of health offer that localized voice, both at a system level, but at a I don't like it when we call them patients or consumers, like they're community members. They're our brothers and sisters and neighbors and so forth. So forgive me for my simple language in that way. I think in our region, we have seen some of the most exciting work happening in our rural communities with our rural health coalitions that have sort of sprouted up out of, I would say, a deep commitment from our public hospital districts and our public health directors, but they have been so inviting to the community where there is a real voice happening, and then those coalitions can connect into some of the system conversations. And I think we're all sort of looking for that easy way to get the consumer voice so we can check that off. But I think if we shift our thinking into this is an engagement of the community, and this is a movement that we're building, that it becomes less about the consumer advisory board and more about we're all in this together.
Can I comment on that? So Jerry, I think it's a great question to ask, and I think it's a challenge because it's scary to ask real people what their needs are. I think that's one of the obstacles. It's easier for us to sit around the table and talk to each other. Much, much easier. It's more comfortable. We don't have to deal with as many hardships. So I think that's sort of one of the realities. One of the ways we get there is to keep that as the North Star. So I'll talk about Premera for just a second. We over the past couple of years have actually shifted what we call our purpose statement or mission statement to actually be about real people and not about health insurance anymore. Kind of funny. Health insurance is about us and it's within our four walls, and I think of people with green lampshades and pencils and calculators. When we think about making healthcare work better, I think about what happens out in the community and the interactions between real people and their providers. So that then becomes our focus and our North Star. And we are now undertaking a transformation where we actually invest in patient-centered design for the work we do. So we have teams who actually go be with patients throughout the entirety of their healthcare experience to understand where the obstacles and issues and barriers are. We'll go with them through everything from their commute to get to the doctor's office, their wait, their experience in the doctor's office, et cetera. All with the intent of trying to understand what are we doing to get in the way of the thing that matters, which is their healthcare experience. And how do we redesign our business processes, our benefit plans, et cetera, as well as our relationships with the providers to be oriented around the singular goal of making that whole experience work better, because when it does, we get back to solving the four problems. So that's one small example of bringing the patient's voice to the table. Sorry to use patient, but in that moment, they're a patient. And unless we have the courage to, when we do that, we blow up. With the first person we follow, our entire business blows up. We're like, oh my gosh, we're in the way here, we're in the way there, we're in the way here. And it's hard to do that work because you have to look in the mirror and actually see yourself. And I think that's maybe subconsciously or collectively one of the challenges we've got is it's really hard to listen to the people who matter. Really, really hard. Because you get told things that are wrong.
Okay, Daryl and then Susie will get your question.
So, real quick point. When I think about healthcare, I'm not sure that I can think of something other than perhaps money that is such emotionally charged. And when we think about health insurance, you've got both factors, right? You've got money, and it's about people's health. Both are emotionally charged. So even though I think that we should continue to streamline and improve processes and improve care, I don't see it as an Amazon. To me, that's transactional, and we've got to move beyond just transactions with people, or patients, and make it more about them. And when I think what I see of some of the pilot programs going on around the state, whether it's in Cascade Pacific and helping graduation rates with some of the students because you're dealing with some of the behavioral health issues, or working on some of the jail transitions. When you're dealing with people and their lives and really helping them, I think that is making a difference.
Good morning, Susie Dade with Washington Health Alliance. I think my question is for Rick and SB, and it goes back to Rick's earlier comment about needing to get to a tipping point in terms of 30 to 40% of the market. From where I sit, we know from our work with the Alliance that there's just tremendous variation in healthcare quality across the state, and that we have quite a ways to go to achieve that goal of sort of top 10% performance in the country. I don't think it's too cynical to say that we're really at the early stage of accountable care with still being much more at an aspirational level than a kind of a producing results level. And I think we also have a very competitive employment market where employers, large employers, are still much more concerned with preserving choice in their benefit packages. So to my way of thinking, this is kind of a chicken and egg thing. Like the purchasers don't really want to go first in limiting choice towards so-called accountable care when they don't actually yet see accountable care. But the providers are struggling with this balancing of fee-for-service and value-based purchasing. So who goes first? I mean, how do we break through this chicken and egg thing to get to the tipping point that Rick's talking about?
SB, you have 3 minutes. I'll comment.
Okay. Susie, you hit the crux of it from a commercial purchaser perspective. Open access PPO is one of the root causes of the problem, right? We talk about financing. There are a whole bunch of root causes. That is one of them. So how do we lead the want? Ultimately, I don't think we'll flip to HMO, right? That's not going to happen. So there's some incremental stage where we need to try to move the market by, I think transparency is the ultimate vehicle to do that, to show group purchasers, here's what you're getting for what you spend. Here's evidence your people are not always getting what they need, they're sometimes getting what they don't need, etc. And in doing so, then we have to bring forward innovative solutions that recognize where they're at today, culturally and from a mindset perspective, but can help address the problem in the context that they've got. So it may not be through restriction, it may be through incentives and encouragement and education if we take that first step. I don't know that we're going to see the market broadly move towards restriction as the first step.
Well, Susie, if this was easy, we would have gotten there already. So my reaction is we will see created new strategic partnerships, and collaboration will mean something different in the future than it has in the past. And there will be a maturation of benefit design to encourage patients to access more effective, efficient providers. And over time, I'm quite confident that we will see 30 to 40% of this market in true value-based payment. From a provider perspective, we are very focused on Medicare. And Medicare offers an opportunity through Medicare Advantage to engage with a partner to structure a financing mechanism that will allow us to make the kind of investments in infrastructure that was referenced earlier for a more sustainable delivery system. So that's one tactic. Second tactic will be, I believe, more creative, narrow network commercial products that will be available in the market that ultimately will produce what you're talking about. There will always be an opportunity to access other providers, but there will be incentives to stay within a system. And even in traditional Medicare, we see patients accessing providers outside of Snohomish County when there's a financial impact to them to do so. And finally, to an earlier comment, I see an enormous opportunity of collaboration between MCOs or health plans and providers to share information in a way that is going to change behavior and how clinicians do what they do. We have seen that to be the case in how we go about prescribing in our setting. And this isn't new, but I mean, we're at about 92, 93%, maybe 94% generic prescription right now. It's a whole different issue in what's happening with cost of prescriptions. But that would not have been possible if we didn't have a relationship with health plans that provided us with all of the data that we did our analytics to share prescribing patterns of all the clinicians in the Everett clinic. We've had a wonderful relationship with Premera over the years, and they pointed out to us we had an opportunity to improve on utilization of ancillary services, particularly high-end imaging. And we took down utilization by 30 to 40%, saved our patients millions and millions and millions of dollars. Given the business model and the lack of alignment on financing, it impacted our sustainability, but it was the right thing to do for patients. So I'm quite confident that over time we're going to move the needle to higher paper value. Nathan, I see that you are ready to take charge. Thank you very much for your questions.